Hello, 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 check one.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبर। कसम है ज़माने की कि सारे इंसान खसारे में हैं मगर वो लोग जो ईमान लाए और अमल साले किए और एक दूसरे को हक़ की फरमाइश करते रहे और एक दूसरे को सब्र की तलकीन करते रहे। तो अल्लाह ताला में अमल की यकीन की तौफीक अता फरमाए। थैंक यू।
जज़ाकुल्लाह खैर। It's really an honor for us कि आप लोग यहाँ सारे तशरीफ़ लाए। वो it all happened in a social media action, and what exactly had when I'm also part of the cornea session, the group, and Professor Dr. Zaman wrote over there that he wants to have a Bowman membrane and whatever he's going to talk about, transplanted. नाम लिए तो हमने कहा यार, and there was a bit of interest up there, and it is possible to do, and it requires these kind of a thing. So, why not? Why not we do it? And then I asked the president, OSP, and he also agreed. So we, but even before that, I had already said to him that we'll do it over. It's on behalf of the Pakistan branch and the president, Professor Amir Yaqub. I welcome you all over here. And I'm really grateful that Dr. Zaman has made all the way from Peshawar, and it shows his enthusiasm and his innovation, which he's doing over a period of time. And I know him for quite a lot of period of time, and he's always there to do something innovative, something new, and which is what is required. And I think so that was the reason why I made an effort to get it done. On behalf of the eye consultant, I welcome you all, and we hope that you will enjoy it. Just to give you a brief resume of what we have got over here. I may not be a cornea man, but we do have a lot of relationship with the cornea. So we have got, it's almost now 8 years since we have started off. When I started off, I thought that it should be a complete hospital, a complete clinic, so that we have all the facilities. So not only that, my basic, I started as a general ophthalmologist, going there to a vitreoretinal specialist, and then being a general ophthalmologist, you have to do everything. So that is how we all were trained at that time. So we, then my other interest, refractive surgery. So we also had the femtolesic and excimer laser over here. And now we have also got, what do you call it, SMILE, which is the clear version of Zimmer machine. And we are grateful that we have now doing all kind of surgeries which is possible, including we have also got a setup to start femto keratoplasties also. So we are also planning, because it's the other important thing is expense, which is there, which we have to think about this thing. So this is what it is. Which we in norm, the name over here, it is clear because SMILE is normally known because the Zeiss machine which is causing over them. So the other thing which we are also doing is about, because everybody is about the keratoconus, and I think so we all know, know about this thing, that the incidence of keratoconus is increasing, I think. So it's not the amount of, and the equipment which we have got nowadays, we can really very easily diagnose them and do this early treatment. So we are doing it not only with the CXL, but we are also using ICRS rings. And then we are also treating their higher order aberrations, and we are also doing partial trans-PRK along with PTK and CXL on our patients, and with a very good results, which we are going to show it. And I think so we have got the highest numbers of patients with all of their record for last almost 10 years now, over 12 years, having ICRS PTK CXL. So I think so we are going to be presenting this within a few, so that we have got a 5 years period of, more than 5 year period of post-fellowship, follow-up of all these cases, and which will be of international standards. And I think so I must congratulate Professor Sadia Mayu on this thing, that she has been able to compile this for last 10 years. We are also doing corneal transplant, and Professor Brigadier Intisar is here, who's in charge over here, who does the corneal transplants here. So, and then it's their innovations, because हम अपनी एक हर लेवल पे पहुंच जाके बंदा कहता है इधर ब्रेकें लगा दे, हम जिस उम्र के उस हिस्से में पहुंच गए, हम ये चाहते हैं कि अल्लाह और कोई नई चीज़ ना आए. So hopefully DMAX and DALC and also FemtoDALC is also possible with us, and that is also we are thinking of those things. With this thing, I think so I will go the moderator to take over the place and plan, and then the next would be to carry on.
Assalamu alaikum. Assalamu alaikum. I welcome you all at the Eye Consultant, and for this workshop, DRLT, which will be conducted by Professor Zaman, and he's here from Peshawar, all the way from Peshawar, to do this workshop. So Sir General Mazhar has already given you a brief about the detail, what we are doing here and what Professor Zaman will be doing in the coming wet lab. And thodi si baat that there will be a live presentation by Professor Zaman, which will be followed by wet lab. But because of the space limitation, so I will request that we'll go in group of threes, 3 doctors at one time, and that will be shown here and from the OT. And after that, in the meantime, we'll have refreshments over here, tea will be served, and we'll go accordingly, according to the turns. So I'll request Professor Zaman to please come over and start his presentation.
सर कुछ क्वेश्चंस भी हैं सर, कुछ क्वेश्चंस भी हैं, जो भी हैं वो हम वेट लैब में डिस्कस कर लेंगे. हाँ हाँ जो भी हो. हाँ हाँ आप ज़रा निकाल लें. हाँ which tissue should be preserved. हाँ ये बहुत ज़रूरी है सर. हाँ ये ज़रा ये मैं चलो चलो शेबाज आवाज. Bismillahirrahmanirrahim. Today we are going to discuss topic in the history of the corneal transplantation, and since 2000 and after that we got number of the procedure, and every 10 years you will see a new procedure. So this today is the turn of the DRLT, donor to refractive lenticular transplantation, right? In the last 10 years we have got CTEC and CARES. This is prevail in throughout the world. But now we come to the donor to refractive lenticular transplantation. We to start. First of all, I would like to show you the video. Most of you have seen this video. So this was the initial case, right? Where I didn't make any protocol how to proceed for the procedure. This is an ordinary lenticule which I have taken. I didn't know before. This was basically the smile-derived lenticule. I have stained the lenticule, and Now we will convert this lenticule into a donut shape to create a negative meniscus. This is the basic mechanism. This lenticule I have started in 2016, but it didn't work. It was the result. But after a long time, when I decide to go for a donut shape, it's really work. And this is the basic of the DRLT. Now this is the Visumax femtosecond laser machine, where this is a case of the advanced keratoconus. And in this you can see there is an acute VKC. In acute VKC, all the procedure they are contraindicated except this donut refractive lenticule transplantation. Now look at the other area, the conjunctiva. There are severe signs of the acute VKC. Now this tunnel is made, initially we keep this as at a depth of the 120 micron. This is the same as we are doing the femtosecond. And we put the criteria in the machine according to the femtosecond. Now this is the lenticule, right? This is the donut, not the lenticule. This is basically the donut. This is the same spatula. Now we are inserting into this pocket. The difference is this DRLT and the femto, we make the hinge larger. And the reverse is true for the femtolasic. Now this lenticule has now been introduced. While looking at the pentacam and to know exact location of the cone, because this donut is placed around the cone. Sometimes this becomes very difficult to unfold the tissue. We do not hydrate the pocket. Sometimes you can hydrate the pocket before insertion. The diameter is 6.5 millimeters, right? And 0.1 millimeter is the transition zone. So this is the beauty of this procedure, that it contains the transition zone. The rest of the cares, CTEC, DELC, whatever the procedure, there is no transition zone. And in this we have the transition zone. So the beauty of the transition zone is that it decreases spherical aberration. There is no photophobia, there is no glare halos. This is because of this transition zone in mesopic pupil. Now, if you look at the center of the lenticule, the pupil, we have put the lenticule all around the thinnest area. Now this has completed the procedure, right? This is so simple, and the best aim I already mentioned is the creation of the negative meniscus. This was the pre-op pentacam. This is the post-op pentacam, and the thing is that if you look at this is basically donut zone, right? Clear. Now what we want to see is the presence of the donut and non-donut area. This is important. And we should go for anterior segment OCT on the first post-op day. आगे हो सकते हैं? वो बेसिकली मैं कहता हूँ कि थोड़ा सा फास्ट कर लें. ये जो इम्पोर्टेंट चीज़ है कि anterior segment OCT on donut area, anterior segment OCT on non-donut area. So जो donut area है वो अगर आपको picture न मिले तो इसका मतलब ये है कि the procedure is not good. And this is what we want. This is anterior segment OCT on area. So this is, there is the lenticule. The lenticule is missing. This is the lenticule. This is the lenticule. And this, in this area, the lenticule is missing. And this is the basic mechanism, and this is what we want in DLT. Mahi, again. you see the whole lenticule is here. So this anterior segment OCT in an area where there was no donut area. This surgery has been performed, I think, two years back. This was that of the initial results where we want to see the keratometry, the topoastigmatism, and the Kmax reduction. And of course, we want to have the best corrected visual acuity. So if you see, there is a reduction in both the K1, K2, as well as in the Kmax. And of course, there was a significant improvement in the best corrected visual acuity. Acha, we go a bit, we will take some time on this, that we utilize the residual circular. आप छेड़े मत ना. This here in DRLT we basically utilize what is the remnant of the smile technique. Why call this remnant? Because we throw it away. So greater lenticule thickness correlate with the improved clinical outcome. Both the donor and the recipient must undergo. Here we don't go for any viral serology in the donor and in the recipient, but this is important, right? So, and I have done in all these cases, and DRLT represent a novel technique where the primary objective is to implant a negative meniscus-shaped lenticule and to reduce the topographic astigmatism. Now, again, this is the protocol, right? One should keep this in mind. Good candidate and contraindication. High Kmax, whatever the high Kmax, high the level of the high Kmax, the good result will be there. And the thinnest location should be more than 370. If it is 370, 360, it's okay. If it is less than that, you will not get the favorable results, right? And those individuals which is ineligible for UV cross-linkage, and of course central cone keratoconus, central post LASIK ectasia, and acute VKC. Already mentioned that in acute VKC, all the procedures they are contraindicated. This is the only procedure you can happily perform. And of course, these are the contraindication where the thinnest location is less than 350 and acute high drops. And of course, the keratocolobus and peripheral cornea thinning. Now, the donut should be precisely placed over the area of the cone, and since the cone is typically located inferiorly or less commonly, so the donut should be more accordingly. Donut-shaped bone layer transplantation follow the same principle, right? So post-operative edema of the lenticule, this typically resolve within a month, so we can go for CX cell after a month. So every patient where we do the DRLT post-op CX cell must be done within a month, right? Because it will give more strength. And you know that immunological reaction will be very much less, but still it is there because we have some keratocytes. Now, why we want to go for DRLT? We want improvement in the best corrected visual acuity, and this is what the patient wants. And we want to slow or stop the progression of the keratoconus, and of course the contact lens tolerance. Whatever the value of the Kmax may be after the procedure, you can go for CX cells straight away. There is no questions, right? And this is the basic mechanism. Backward thickness law, the corneal shape change induced by adding or removing the tissue can be predicted. Adding the tissue to the peripheral cornea or removing it from the central causes central corneal flattening, and this is what we want. Now, this is, I don't discuss this, right? This is the comparison between the DRLT and the DELC procedure, but one thing I would like to mention you, that if you see a crystal clear cornea, we decided to go for DELC. Why we decide to go for DELC? No question eyes, because of the reason if the patient is fit for DRLT, the first choice is the DRLT. The thing is that if we go for DELC, we transplant a bulky tissue, and we apply 15, 16 suture, which is non-biological, and it stayed here for 8, 9 months. So how the patient will tolerate these numerous sutures? And the thing is, these sutures, they get loose. in younger individual, and the procedure is done most of the time in younger individual. So these loose suture, they feel like a foreign body, severe foreign body sensation, mucus plug collect in that area, and they, the loose suture encourage vascularization, and the loose suture become infected, and you will be then you will remove these suture, and of course this may result into corneal ulceration. So you can shift the patient to the OT and apply the suture again and again. And on removal, you shift the patient again and again. And most of the tense patients, they develop abdominal pain while waiting outside the OT for removing of the sutures. So DRLT is basically safe and clear from all these complications. And if you look at the in DELC, basically keeping in mind the bis-corrected visual acuity, which is quite good in DRLT. This is basically DRLT and CARES. This technique is worldwide, globally accepted. All the people they are doing. I will be doing all this in some presentation, that what is the difference between the CARES and the DRLT, right? But if you look at in CARES, actually, it's cover only DRLT 360 degrees circumferential. It's cover only one or two segments, right? Both vertical and horizontal meridian, they are flat. This is the quality characteristic of this procedure. But there is segmental flattening. Biomechanical strengthening, it provides significant strength. There is some reinforcement. And CXL can be done after a month, possible but variable, because application of the single strips in CARES does not mean that you should go for CXL. Now, tissue visibility in CARES, if you look at the visible tissue, cosmetically unacceptable, that result into photophobia, glare, halos, spherical aberrations, while the DRLT is basically free of all these problems. Basically, this CARES, both the procedure can be done with a femto, but the CARES can be done manually. I mean, there is manual dissection. You can perforate the cornea. And DRLT, it's a biomechanical integration. It's become part of the cornea. While if in this very difficult tissue will then be visible, in CARES, the tissue is visible lifelong. But this is how I did a comparative, but we will not discuss it over here because we will mainly stress on the wet lab course. This is the importance of the transition zone, right? The transition zone in